linkage to treatment is by leveraging use of our state public health laboratory. So this graph shows annual testing volumes at our state lab for HIV, Hep C, and syphilis from 2013 to 2019. And you can see that in October 2014, we discontinued support for rapid HIV testing and started requiring our funded agencies to send serum samples to our state lab. You see an immediate uptick in HIV testing the following year. And in that following year, we implemented automated HIV Hep C antibody co-testing, leveraging those higher HIV testing rates to boost Hep C screening as well. And then more recently in 2018, we implemented reflex testing for hepatitis C to address suboptimal confirmatory testing and to further support linkage to care. Oh, sorry, there's something popping up on the screen. Okay, there we go. So in addition to sending specimens to our state lab, we also require agencies to send a data collection form to us. The list on the left gives you an idea of what we collect on that form. And all of this information gets entered into an electronic PDF smart form, which has some data validations built in and also captures all of the data in these scannable barcodes that you can see screenshots on the right. So the ITLS or the service data pages are sent to our office, and the specimen submission forms are sent with specimens to our state lab. Now, because it's all collected in the same PDF, information from the ITLS form transfers down to the specimen submission forms, and that allows us to later link our ITLS data with lab results and surveillance data. So data integration and collaboration has been a priority that's been set at the bureau level by our leadership, with the intention of strengthening surveillance by ensuring we have data elements that aren't typically available through traditional surveillance so that we can accurately characterize populations and the impacts and dynamics of disease within them. And also because it strengthens programs by providing timely and complete data to inform public health action. So the Office of Healthcare Planning, where I sit, is in a unique position to facilitate this, as we aren't part of one group in our bureau, but work closely with all of them, from the lab to informatics to the various disease-specific programs. And finally, I just wanted to mention that the skill set in our office is varied, and that has been essential. We can not only analyze and report out data, but we can communicate that adequately to support technical assistance and capacity building. So this is one example that I wanted to show about how we are using prevention data to enhance our surveillance data. So the majority of hepatitis C cases reported to DPH are done so via electronic lab reporting, and case report forms are mailed to providers to collect additional information. And a good chunk of those case report forms never make it back to us. When we started this work, actually, it was around 40% of case report forms that weren't returned. And as I mentioned before, because we require our testing sites to use our state lab, we're able to match surveillance data to our service data and boost surveillance data quality for the cases that are identified at our testing sites. So in the upper right, there's a schematic of what the data flow looks like, which I won't go through for time's sake. In the bottom right, you can see the data elements that we are sending to surveillance from our testing site data. But the big takeaway here is the graph on the left. So this shows the percent completeness of 5 key variables for a subset of cases that were identified at our testing sites. And that's data completeness is reported through routine surveillance and then through our ITLS for testing sites. And you can see right away that our service data has significantly higher completion rates for some of these variables. So integrating this data into surveillance is really making a big impact for these cases. On the flip side, we've also used surveillance data, specifically lab data coming from ELR, to enhance Hep C linkage to care at our programs. So again, in the top left is the same schematic, which I won't go into. Sorry, did somebody say something? Okay. So here we're looking at to see if clients who are testing positive at our testing sites ultimately have a subsequent RNA or genotype lab as a proxy for being linked to a treating provider. We create reports and review them with them. And it's not seen as like an evaluation or of their program or performance, but it does start a conversation. So we review and discuss the reports, and it gives them an opportunity to clarify DPH expectations around linkage to care, and it also allows them to identify service gaps. And finally, I will just mention ESP very, very quickly. ESP is a platform that sits on top of EHRs and sends cases of reportable disease directly to us with pertinent information like medications and symptoms. We currently have 10 installations statewide, which we estimate cover healthcare providers for approximately 50% of the state. 5 of those installations are currently reporting acute and chronic Hep C, with 2 more likely by the end of this year. We're currently already using ESP data to inform HIV data to care activities, and we have plans to use medication information to further inform our Hep C linkage to care work. Specifically, ESP will give us the ability to create a cascade for Hep C, which isn't solely based on labs and proxies. We'll be able to see diagnosis to evaluation to treatment initiation and completion, and look at intervals between those steps in the cascade, and characterize interruptions, look at information by facility, that sort of thing. So sorry, I ran through that really quickly, but thank you again for giving me the opportunity to present today. And thank you to my colleagues who are listed here, who I collaborate with in this work and help prepare for today. My email is there if you have any questions at all. I welcome people to reach out, and I've listed the mass.gov Hep C website as well. Thank you.
Great, thanks so much, Monica. Next, I want to turn this over to Nadine from New York City to talk about their experience.
Yes, good afternoon, everyone. I'm Nadine. To say right away, my internet connection is unstable, so I'm going to have to turn off the video so that we can stay connected, and you will be able to see my slides before I drop off the connection. So I'm going to turn off the video, but nice to see everyone, and I'm going to share my screen now. Okay. All right, you should be able to see my screen. Okay. Oops. How do I go back to here? Okay. So I'd like to talk about how we used surveillance-based dashboards that are facility-specific to support quality improvements in the New York City Health Department and at healthcare facilities across the city. I am program manager in clinical practice facilitation and work with different healthcare organizations in New York City to increase their capacity to screen and treat for hepatitis C and hepatitis B. And just for background, our surveillance data is reported to the health department through electronic laboratory reporting since 2006. And the data we collect are positive Hep C antibody, positive and negative Hep C RNA tests, and genotype. And those reports include the name and address of the ordering facility. And our surveillance team used these data points to develop 2 metrics: the RNA confirmation, which is the percentage of people with at least 1 positive Hep C antibody test who have 1 RNA test ordered within the 3 months at the same facility. So not per se reflex testing, but a positive RNA test that follows within 3 months of a positive antibody test to confirm that the diagnosis was confirmed. And then the second metric is treatment initiation, which is the percentage of patients that were assigned at the facility that received at least 1 negative RNA test following a most recent positive RNA test. The negative RNA test is a proxy to indicate treatment initiation, and our surveillance team attaches or assigns the patient based on the location of the report the last positive RNA test reported to the health department. And then if there is at least one subsequent negative test that comes from the same facility, treatment initiation is attributed to that facility. Otherwise, it's attributed to any other facility in New York City elsewhere. So we started distributing Hep C dashboards annually starting in 2017. We started with one metric, which was the RNA confirmation metric. And then in 2018, we added the treatment initiation. And in 2019, we had a more complete report with the number of antibody tests performed at the facility. And I'm going to go in more detail on the most recent report, the 2019 dashboard that we used. So the Hep C antibody testing was the top part of the report, which showed the volume of Hep C positive antibody tests at a facility over 3 years of data. So they could see if there was a trend between 2016 through 2018. We also added the RNA confirmatory rate. So the organization could see how they were doing over 3 years in the first part on the left part of the graph. And then on the right part of the graph, they could compare themselves to the 40 acute care hospitals to which the dashboards were distributed over the same time period. And we added a goal that the health department had, the 85% RNA confirmatory rate, which is based on the fact that any organization that had already implemented reflex testing, which is any positive antibody test automatically reflects to an RNA test, achieved at least 85% RNA confirmatory rate for this metric. So, and the bottom part of the dashboard was treatment initiation. So it was a visual when we showed the total number of positive cases at the hospital during one calendar year, and following that algorithm, looking at negative RNA test, the following calendar year, identifying how many or the percentage of those patients who initiated treatment. And we also added a link to our annual report and information whether they wanted to get more information on. They also had our email, and the back of the report, if they printed it, also included FAQs where we added the definition of each one of those metrics and additional information to get in touch with us. So the dashboards were really a tool of the clinical practice facilitation program to engage providers and hospital leaderships to increase their capacity to screen and treat through clinical training. It also helped us identify facilities in need of support to implement reflex testing. We offer them a EMR query tool so that they could query their EMR and monitor their patients through the care continuum. And we also, it also helped us promote initiatives to support patient outreach and improve linkages to care. And this is some of the responses we received from hospital leadership during that time period, which was not all positive, but these three happened to be positive, where they really tried to use this data and those dashboards to engage with hospital leadership to make system upgrades and implement quality improvement projects. So the main limitations of the dashboard and using surveillance data to develop these dashboards is the patient assignment in the treatment initiation metric, which is can be challenging when there's missing data, missing address in the report. Also, provider information is not always standardized. But some of the lessons learned are that the dashboard supports situational awareness, where we understand more what's happening at each hospital around hepatitis C and how we can help them improve their system through targeted technical assistance and roll out full quality improvement projects with those hospitals. It helps us build relationship with the providers at the facilities, and it requires, though, that we have a comprehensive surveillance system, that we have a queryable system with the data points that I mentioned earlier, positive antibody, positive and negative RNA, and genotyping, as well as address and name of the provider. And it requires also an extensive analytic and programmatic time and capability. So in terms of staff, we have staff in our surveillance team and in our program team that are working together to create those dashboards. And also the reporting needs to be include both negative and positive Hep C RNA test results. So I think that's in a nutshell how we used the Hep C surveillance-based dashboards over a three-year time period. And this work, as I said, was done by very dedicated staff at the New York City Health Department in the viral hepatitis program. My email is listed on this page. Thank you.
Great, thank you, Nadine. And that brings us to our third speaker for the session, Dr. Thomas, who will speak to us about her experience in Oregon.
Hi, give me a second to bring up my presentation here. Oh, okay, great. Let's see. So I'll be talking today about other data sources that you can usually find lying around your local or state health department that can enhance your hepatitis surveillance data. So the things that you can usually access are the various, what I would call sort of health services data or claims data, such as hospital discharge data, Medicaid data, and sometimes in our state, we actually are able to access an all payer, all claims database, which includes other insured persons. Most of you should be able to access your state cancer registry. And then lastly, there's all kinds of very useful vital records. And so the kinds of things that you can use this for is that you know, sometimes incidence of acute or even chronic hepatitis C is a bit of a kind of a squishy outcome. It doesn't really mean what people think it means, but liver cancer, that's kind of a hard outcome. And as you'll see in some of my data, like we are starting to see declines in liver cancer with the advent of better treatments. That's a worthwhile thing to track. The other thing is we've done some things to, because Hep C in pregnant women is not reportable in our state, we've been able to access birth certificates to get at that data. And then, of course, another big thing that will usually is impressive to your stakeholders and to policy people is to be able to track deaths attributable to hepatitis C. Another outcome that is important to track is just kind of sequelae of severe liver disease. So typically, you can track things like cirrhosis, liver cancer, liver transplants through hospital discharge data. And then lastly, if you have Medicaid or all patient, all claims data, you can actually look at the number of people who are being tested and treated for hepatitis C. So kind of some of the uses of this. I think the first type of important use is to be able to document the burden of severe disease, such as liver cancer, hospitalizations, and deaths. And I had seen our state cancer registry had published some data showing that liver cancer was the fastest increasing cancer in Oregon. And honestly, their article really did not even try to guess at the cause, although of course I immediately leaped to the conclusion, well, it's probably related to chronic hepatitis B and C. But although cancer registries collect a great deal of demographic data and data on stage of which person presents, they don't include that little bit of data. So we did a linkage project where we took cases of liver cancer going back to 1996 when the cancer registry started, and we linked it to our hepatitis B and hepatitis C surveillance data. And hepatitis B has been reportable since the late 80s. So you can see some blue cases related to hepatitis B, and then lab markers for hepatitis C didn't become reportable until 2005. And by our algorithm, you couldn't be counted as a case of liver cancer due to hepatitis C unless your positive hepatitis C result preceded your diagnosis of liver cancer. So of course there weren't too many in this early time period, but later on it became a larger and larger share. And by 2012, chronic hepatitis B accounted for nearly half of our cases. And of course, I'm dying to update this data. And then of course, the other thing is you can look at hospitalizations, which are key. And there we found that the best thing to do is to, it's pretty non-specific just to look at people who are hospitalized with hepatitis C, because you'll find that a lot of them are in the baby boomer age group, and they could be, the reason for their hospitalization is probably more likely related to having their hip replaced or having a heart attack. So we included, created an algorithm so that also required a diagnosis of something like cirrhosis or ascites or liver cancer to improve the specificity of that finding. And then for deaths, we look at hepatitis C in any of the fields contributing or underlying, because that's how CDC does it. And so people will say, oh, how do you know that? Because, that death was really due to hepatitis C and not anything else. And the answer is, well, I actually don't, but this is how CDC measures it. And in fact, our cases in Oregon are twice the national average for hepatitis C mortality. So that became a very convincing metric to stakeholders around the state that we needed to do more around hepatitis C. Another reason to use other data sources is that sometimes it helps you track down cases that are hard to find, like infants exposed to hepatitis C. And as I mentioned, or actually, I think I first read an MMWR that was published in 2017 that reported increases nationally in deliveries among women who are hep C positive, and that was using birth certificate data. And up until then, I honestly did not even know that Oregon included this information on birth certificates. So I immediately got a hold of like the last 10 years worth of data, and I couldn't document an increasing trend, but I knew that they were probably underreported because typically the person in the hospital who fills out the birth certificate is just looking through medical records. So unless the mother has been tested, as part of that pregnancy and in that same health system, it's not going to be reported. So again, we did a linkage study where we took birth certificates, any live birth in the year 2015, and we looked at women who were reported with hepatitis C in the preceding 15 years, and found that, originally when we just looked at birth certificates, we found 180 women who had hep C reported on their birth certificate. But after this cross-match, we identified another 113 women. So we had a 60% increase in the likely number of infants who were exposed. And I can certainly tell you that, based on the fact that we would think that, 6% of infants might have acquired hepatitis C, we do not have that many cases in our registry. So this is, we haven't had much time to, or had the staffing to do much with this. This is something we want to, focus on in the upcoming 5 years, is how to start tracking down these infants and assuring that they get the testing. Another important use of these data is to measure access to testing and to treatment. And here, this shows, this is our all payer, all claims data set, which includes Medicare and Medicaid, although unfortunately not VA or military insurance. But since we do have the Medicaid waiver, 95% of Oregonians are now insured. So it's become a much more complete data source than it used to be. And of course, you could also get demographic data along with the medical claims and the pharmacy claims. And this was just a simple query to identify how many people initiated treatment, but we've been quite gratified to see that the numbers have gone up starting in 2015 when direct-acting antivirals became available. And then lastly, of course, we're all going to be developing elimination plans, and you want to be able to monitor the trajectory of the epidemic. And as I mentioned before, just positive lab results for hepatitis C are not a great marker because they measure incident cases that may have occurred decades ago. And it's also heavily dependent on the availability of testing. So if we all do our jobs and promote testing, the number of positives is of course going to go up. Conversely, if testing goes down, as it did in most of our states last year, that's going to be important for us to track over time. So I think one of the things that we need to do is to continue to track most of these other things like the sequelae, like death cases and deaths from liver cancer and the hospitalizations and the deaths, as well as things like, as I mentioned, so in my previous slide, it's going to be important to look at who's getting tested and who's getting treated. This is a very gratifying slide. I haven't had the resources to do a match with our cancer registry in the last year, but I did look at just cancer registry data from earlier this year. And what's interesting is that if you look at 2015, when treatment became more, good treatment became more widely available, that really cases of liver cancer and deaths in Oregon have started to taper off. So I'm really curious to see, when we can get more updated data, what this looks like. So the key to getting started is really just to figure out who holds the data in your health department or agency. And a lot of the times, you just ask around other people in your section, or oftentimes HIV might be using this, or immunization, or even in chronic disease, someone else might be using one of these data sets. And typically, at least in Oregon, our vital records and the cancer registry is in the public health division. But I had to go outside that to our Medicaid division to get their data, or to get, it's in our health services division where I'm able to access hospital discharge data for the all payers, all claims. The next biggest thing, and honestly, the thing that probably takes up some of the most time about this, is you have to write data use agreements. And so you'll have to get good at, and it varies. Some of them have a very simple form where you write out your purpose and what it's going to be used for. Others need to know, it's more like a protocol where they need to know what your objectives are, what kind of, exactly what data points you need, and what your analysis is going to look like. And typically they'll want to know about your, how you will be handling the data, how it will be transferred to you, how you will maintain data security. And typically, I'm shameless. I don't like to think of it as plagiarism, but I also, since I've just asked my friends at HIV how they got the data, I will ask them if they can share some of their recent data use agreements with me, because your purpose is different and you might need different data, but probably how they're holding the data confidential is like a section that you can kind of lift for your own data agreements. The other thing too is that, again, depending on if their needs dovetail with yours, sometimes we can get people from the all payer, all claims, or the Medicaid departments. They do have their own data analysts and can sometimes do some simple queries for us. So you might be able to at least get some basics on the number of people tested or treated, even if you don't get all the, even if you can't get it stratified by age or race like you'd like. And then I'll make up a pitch here for Link Plus, which is the software that I have used to do some of these linking between like the birth certificates and our Hep C database, or between the cancer registry in our database. It's a free software that you can get from CDC, and it's really like a few pages of instructions. It's something you could sit down in an hour and start using. So I'll wind it up. I'll just say that feel free to reach out to me if you want more information about some of how we did some of these analyses. And because I didn't really have time to go into them, I've put the links here that I'm sure will be shared with you, so you can get more details on how we did the matching and what our algorithms were for defining a hospitalization due to hepatitis C. And then lastly, this is the link to where you can download Link Plus and get the and download the software and get instructions.
Great, thank you, Anne. And
sharing here.
Great.
Actually, are you able to do that? I'm having trouble bringing up the whole page again here.
Great. Actually, and I know we're just a little over time. So just in the interest of moving things along, just going to try to wrap up our session. I want to thank all of our panelists for this very informative session. And unfortunately, as a result of our earlier technical difficulties, we do not have time for discussion, but I do encourage you to follow up directly with our panelists if you have any questions. We'll now hand things over to Lori for Surveillance Panel B for putting data into action using available data to inform elimination planning. Thank you everyone for joining this session.
See. Okay, so now I have video and microphone. Welcome everyone. Thank you for joining Surveillance Panel B, putting data into action using available data to inform elimination planning. My name is Lori Barker and I'm a statistician with the Division of Viral Hepatitis at CDC. I'm the moderator for this session and also will give the second presentation today. So this session will provide an opportunity for viral hepatitis staff to discuss their vision and plan for an innovative approach to viral hepatitis elimination planning. Participants will share input to help inform jurisdictions of strategies for the creation of their elimination plans in state and local data. Joining us today are Paige Armstrong, who's the Associate Director for Global Health. She's also a medical doctor and a commander in the U.S. Public Health Service and the Division of Viral Hepatitis at CDC. And also Cassandra Bush, an epidemiologist with the Center for Viral Hepatitis, Infectious Disease Prevention and Health Services Bureau in the Maryland Department of Health. We'll start with remarks from each of our panelists. We have about 7 minutes each. I'll definitely try to go faster for mine. If we have time, we'll do the Q&A, 10 minutes at the end. We encourage you to enter your comments and questions in the chat box throughout the panel. And Alex Eanes will also be monitoring the chat if you'd like to place questions there. So now I'll turn it over to Paige Armstrong. Paige.
Great, thanks so much, Lori. And I'll go ahead and share my slides. I hope everyone can see them. Great. So yeah, thank you again, Lori, and thanks for inviting me to be part of this session. As Lori mentioned, I'm our Associate Director for Global Health in the Division of Viral Hepatitis at CDC. And what I'd like to do is just share an overview of some of the international guidance that is both available as well as some that is forthcoming to help contextualize some of the strategic plans and targets that may be set both at the national level and then at the jurisdiction level. I think many of you are probably aware of the Global Health Sector Strategy on Viral Hepatitis that was put in place in 2016 and adopted at the World Health Assembly. This remains in place through this year. However, there are plans to update it with a new Global Health Sector Strategy to run from 2022 to 2030. Here, I just want to demonstrate a comparison of some of the 2030 targets that have been put in place or are in place with the Global Health Sector Strategy, the current one, and then how that compares to the U.S. National Strategic Plan 2021 through 2025. On the whole, they're very similar, if not identical, but I'll run through them just very quickly. The high-level ones are that new infections, there's a target of reducing acute infections or new chronic of both B and C by 90% by 2030, mortality reduction of 65% across both, HPV vaccination to increase birth dose uptake by 90% or to 90%, and then treatment targets of treatment of 80% of individuals. So again, very, very similar across both the GHSS and the National Strategic Plan. This is a newer document. It's called the Interim Guidance for Country Validation of Viral Hepatitis Elimination. It was just released by WHO in June of this year, and it was a response to requests from multiple countries for a framework to achieve list targets to be certified for elimination. It's currently in draft phase, and it will be updated throughout this year and into next year, with the final version being published in spring of next year. But at present, it does outline some particular targets that I wanted to highlight. There is a shift in this document also towards absolute targets, with the HBV incidence target being less than or equal to 0.1% of Hep B surface antigen prevalence in those 5 years and younger. For HCV incidence, it's 5 or less per 100,000 persons in the general population, and then 2 per 100 in PWID. And for mortality targets for both HBV and HCV, it's either a combined rate of less or equal to 6 per 100,000 persons, or 4 and 2 respectively for HBV and HCV if cause-specific or cause-attributable mortality is available. In this document, there's also programmatic targets. They range from coverage of HBV vaccine birth dose to testing and treatment, prevention, and even some IPC and healthcare related, such as 0% unsafe injections, 100% blood safety, and then for harm reduction, 300 needles or syringes per PWID per year. Within this framework, there are also different options for certification of elimination, ranging from EMTCT of HBV as part of triple elimination, to HCV alone as a public health problem, HBV as a public health problem, and then an all-inclusive option of HBV and HCV. So there's been a lot of individuals involved in providing feedback on this particular guidance document. Again, it's in draft phase, and they're continuing to receive, WHO is continuing to receive feedback throughout a pilot process that's ongoing this year with 6 pilot countries. But some of the challenges that have been anticipated are age-based. One is that inclusion of only children 5 and younger will limit some school-based surveys, which are very widely used, especially in an international setting. For incidence, it can be challenging and difficult to have good, complete, and timely annual incidence data. For mortality, as we all know, cause-specific vital statistics can be limited and may underestimate numbers. And then with absolute targets, we recognize that there are some limitations in that while they assess total risk to the population, there's also utility in retaining relative reductions to demonstrate progress. So just as a bit of a benchmark or a way of comparing how the US stands on some of these country validation targets, for Hep B surface antigen prevalence, we don't have complete information on this, and so it is a bit of a question mark with relation to the specific target number. For absolute annual incidence of HCV, we do have numbers for that, and it's 1.3 per 100,000. However, we also, I think, all recognize this may underreport. We do not have complete data on PWID and incidence in that population. And then for mortality and attributable mortality, I think, again, we appreciate that while we might reach the absolute target, there's also an underappreciation and maybe underclassification. So I'll just highlight that within this document, there are some outlined alternative metrics and measures that one can use for all of the targets that are listed. But I'm just using one example, which is incidence. They list that the gold standard or the preferred measure would be a direct measure through a cohort design, a prospective cohort study with people being tested at regular intervals. Alternative approaches, though, that are listed would be monitoring viremic prevalence among those who screen positive, or monitoring incidence trends using acute infection data. So as mentioned, there is a timeline for this guidance. It was presented and published as an interim draft in June. There is currently undergoing pilot in 6 countries, and we're supporting a few of them, and that will end in the end of 2021. And then by spring of next year, we anticipate this to be finalized and published as a framework. Thank you very much, and I'll turn it back to Lori.
Thanks, Paige. All right, is everyone able to see my slides now?
Yes.
Great. Just move a couple of things here and be right back. Right, so Paige has given you the view of the global landscape for elimination, including the very recent interim guidance for validating progress toward or achievement of viral hepatitis elimination goals. In this presentation, I'll step back for a moment to how goals and targets for the US were developed and aligned across plans over the past few years. I'll end with some, I hope, very practical suggestions for developing or aligning jurisdiction and partner organization goals. So first, let's look at the US plans. The CDC Division of Viral Hepatitis and HHS strategic plans aligned with each other, setting targets for 2025, but they also set targets for 2030 aligned with Healthy People, the WHO Global Health Sector Strategy, and the National Academy Strategy for Elimination of Hepatitis B and C. The National Progress Report is a complementary publication. It tracks progress toward 10 indicators specific to CDC's role in viral hepatitis elimination, focusing on new infections, cases among people who inject drugs, and deaths from chronic viral hepatitis overall and among groups experiencing disparities in death rates. So let's look more closely at the measure sets considered in the alignment process. We'll start with Healthy People. Viral hepatitis objectives have been part of Healthy People since the first set of goals for the US were set for achievement by 1990. The number and structure of the indicators have changed over time, but they generally track with consistent concepts like new infections, awareness of chronic infection, and deaths. The figure on the right just illustrates that a decade is a long time and much can happen that might change how we view the objectives being tracked. And this past decade was particularly active for viral hepatitis in terms of recognition of the impact of chronic infection and the need for elimination planning, plateauing of hepatitis B infections, and dramatic increases in hepatitis A and hepatitis C infections. 3 key publications provided measures and targets for consideration and alignment from the Institute of Medicine in 2010 at the left, the World Health Organization in 2016, and the 2017 National Academy's assessment of the feasibility of viral hepatitis elimination for the US. So now let's look at alignment. So first of all, why align at all? Alignment addresses common criticisms of measures and measure sets, that there are too many measures and that they're not coordinated, that the selected measures are not the most important or most relevant measures to track, or that the estimates are not accurate or timely. The table on the left addresses the first criticism, if you followed this example, by reducing the number of measures and making them the same in all sets. But clearly it's in conflict with the second criticism that the measures aren't relevant to some partners. The table on the right shows a small example of aligning measures by concept, but selecting measures for each set that are relevant and measurable for each group that uses the measure set. Some of the measures could be the same across different plans, while others may differ. So how might indicator selection proceed? The logos on the right just illustrate there are many partner organizations who might have their own indicators already or have some interest in indicators being selected or aligned. The gray dashed line between CMS and CQMC just illustrates that national partners inside and outside of federal government have existing relationships, and some of those may be focused on measure development, which could also be of interest to jurisdiction level partners. So first task is to measure, to list out the measure sets that might be sources of indicators and compile those indicators and organize them into a crosswalk or grid by concept. Then next, consider data availability, how often data are collected and published, whether the source or summarized data are publicly available. And then using this information, select a minimal set of high priority indicators and then organize these by relating them to the timeline for reporting. That is how many data points will be available between baseline and 2030 in this case. And then also align them with indicators used by other partner organizations or the national plans. The purpose of this last step is so that you can say clearly something like this. If my program drives improvement in my indicator, then our partner or national organization should see improvement in their indicator, because the forms at the top of the slide are just examples of worksheets that could be used to compile the information and the steps presented on this previous slide. And many of you who've already been through this exercise may have your own examples. So now that the indicators have been selected, how might the targets be set? So the discussion of target setting could be vibrant. There are simpler and more complex approaches to setting targets, from expert opinion to sophisticated modeling or forecasting methods. So consider the feasibility of achieving the target, as well as the feasibility of implementing the target setting method, communicating it to partners in the program and in the public. And then also thinking about how achievement of elimination will be validated. The WHO interim guidance might be useful for that, although it wasn't available at the time the targets were being set in healthy people. So for the national and CDC strategic plans and for healthy people, CDC's National Center for Health Statistics provided guidance and an Excel file tool, and then very kindly published these on their website for anyone to use. They also incorporated feedback specifically from DVH during development of these tools, and we really appreciated that. See, my slide's not moving. There. Okay, here we go. Healthy People 2030 launched before the National Strategic Plan was published, so changes to a few targets and one objective to align with the plan were requested after launch. This illustrates that alignment can become kind of a lifestyle after the initial effort. So setting up some processes at the beginning of planning to support decision-making about revisions or realignment could be helpful over the course of the decade. Okay, and finally, when you receive these slide sets, this last one just has links to all of the resources mentioned previously. So now I'd like to turn it over to Cassandra for her presentation.
Thanks, Lori. Okay, can you see my screen?
Yep,
Yes.
we're all good.
All right, so I'm Cassandra Bush. I'm the epidemiologist for the Center for Viral Hepatitis at the Maryland Department of Health. And I was just going through our hepatitis C path to elimination here in Maryland. So this is our mission and vision for the Prevention and Health Promotion Administration here at Maryland. And we just want to highlight that we want to promote healthy individuals here in Maryland, and families can enjoy optimal health and well-being here. This is our Center for Viral Hepatitis. It's made up of myself, our Viral Hepatitis Prevention Coordinator, Odetta Dotson, and our Center Chief, Towu Olurolu. So for those of you who may not be as familiar with Maryland, here's some basic demographics. So our state has just over 6 million residents. For our gender demographics, it's roughly nearly 50% female and male. And then something that's interesting to highlight, for our race ethnicity, it does not mirror what you see on the national level. So our Black non-Hispanic demographic is much higher than what you see nationally. And then our Hispanic is lower. So here's an overview of our viral hepatitis C burden in Maryland. And so from 2015 to 2019, reported to our National Electronic Disease Surveillance System, or NEDS, which we collect our surveillance data with, there were 262 acute hepatitis C cases reported. And then there were nearly 25,000 chronic hepatitis C cases. And so the graph here to the right, the one at the top is just displaying the trend of hepatitis C cases reported for acute. And then on the lower bottom is the trend for chronic hepatitis C cases. And as you can see, from 2015 to 2019, we actually saw a decrease in electronic reported chronic hepatitis C cases. The map at the bottom displays the geographical distribution of chronic hepatitis C cases throughout Maryland by jurisdiction. So we have 24 counties, which include 24 jurisdictions, one of which includes the city, which is Baltimore City. And as you can see, if you remember the population demographics, majority of the population is congregated in the central and southern region of Maryland, so here. But if you look at the rate of chronic hepatitis C cases, you can see it's more so in our western region, in Allegheny County, Washington County, and then some here in the eastern area, Somerset County, and then Cecil County as well. So now I'll just go over our path to hepatitis C elimination. So back in 2018, through funding that we received through ASO, we were able to work with the Center for Disease Analysis Foundation in order to identify and to quantify the prevalence of hepatitis C in Maryland, which you all know, working in viral hepatitis, especially hepatitis C, it's really hard to quantify the prevalence or identify the incidence of individuals, but it's really important for elimination because you need to know the numbers that you're working with. And so we were fortunate enough to receive funding in order to come up with our estimate. So it was estimated that 1.2% of Marylanders, or 72,000 individuals, are chronically infected, and this was as of 2017. And the CDAF, they used data from the health department, from our Maryland Department of Public Safety and Correctional Services, which oversees our incarcerated individuals in Maryland state facilities. They used CDC data from NHANES, and then they also were able to estimate the HCV RNA prevalence among homeless individuals, among individuals incarcerated, among individuals born 1945 to 1965 or baby boomers. And this really helped get the ball rolling for us here in Maryland to move towards elimination, because now, beginning in 2018, we had an idea of the number of individuals affected, currently infected with chronic hepatitis C outside of our surveillance system. Next, and which is linked here, they developed the Maryland Hepatitis C Strategic Plan, and beginning in 2018 was development, and then it was released in 2019. And this is basically a broad-based plan addressing hepatitis C in Maryland. And here are the four main pillars that the plan is based on. And as you can see through the graphic, the pillars are integrated. So we want to work on prevention or preventing new infections. We want to enhance and increase testing for hepatitis C, specifically among individuals who are at high risk. So persons who inject drugs or PWIDs, individuals who are co-infected with HIV and other high target areas. And then we also want to focus on treatment expansion, over the years with direct acting antivirals being so successful. We want to increase accessibility. We want to also review any restrictions that we may have in place as it relates to treatment. And then also we want to take prevention, testing, and treatment and integrate all of this information and data into our surveillance, so that we're not just collecting electronic lab report information, but we're enhancing our surveillance to make sure that we're capturing treatment data as well. Then over the last 2 years, we've developed our Maryland viral hepatitis epidemiological profile, And our profile is not just based on hepatitis C, it also includes data on hepatitis A and B. And this profile, we use data from several sources throughout Maryland. As Anne mentioned in her presentation, we reached out to a lot of departments here in the health department to collect data, but then also reaching out to other individuals and other sources to present data on not just hepatitis C infections, but hepatitis A and B. And so our EPI profile, we are hoping will serve as a base document that will help us to move towards elimination. And here's just some screen grabs from our hepatitis EPI profile. It's over 150 pages long. It's a data-driven report. Majority of the data presented is in graphs, maps, figures, and then we have like a plethora over probably like 70 pages of just appendix data tables. And we hope that this information will help increase awareness and knowledge of not just viral hepatitis C, but A and B as well throughout Maryland. And also we can use this data we presented here towards our elimination. So the next steps will be to measure our data points that we presented in our EPI profile over time. Also, too, we want to combine our strategic plan and our EPI profile into actionable items. So we want to develop a viral hepatitis C action plan in our steps to move towards elimination. We will continue to use local and state level surveillance data and evaluate key indicators that we've set up for elimination. We also too don't just want to focus on what the health department wants. We are going to collaborate with stakeholders, including our Maryland Hepatitis Coalition, in order to get different voices in on the planning and development of our elimination plan and what they feel may be feasible. The Maryland Hepatitis Coalition is made up of providers, of local health department staff, of community-based organization individuals. And so we believe that this will help enhance our elimination plan. And then hopefully through all of this planning, we'll be able to disseminate an elimination plan for viral hepatitis C in Maryland. So here's just a timeline, as you can see, and then some of the stuff that I did not mention that you may want to consider as you move from your data to elimination would be, we were able to use our strategic plan in order to get hepatitis C RNA negative reporting mandated here in Maryland. Also, too, we were able to use our strategic plan and some of the data presented and the expansion of our testing for hepatitis C in order to have the removal of all hepatitis C fibrosis restrictions for Medicaid treatment requirements removed in 2020, which was, a huge step for treatment. And then hopefully in the future, as I mentioned, we will continue to evaluate measurable data points that we presented in our EPI profile, develop our action plan with the documents that we have and the data that we have, and then develop an elimination plan. And I just want to give a special thank you to NASDAQ for inviting me to present today, as well as the Maryland Department of Health and everyone who made this presentation possible. Here is my contact information, and the scan code is to my LinkedIn, so feel free to link me, and thank you so much.
Thank you so much to the presenters. NASDAQ has given us about 1 more minute so if you have any questions, please ask them. I'll also look at the chat. I do just want to remind you that we'll be switching to a different Zoom link at 3 o'clock, and I put that in the chat as well. I saw quite a bit of discussion about the EPI report being very helpful in providing statewide data, and some comments about what can be what CDC might be able to provide for all jurisdictions versus data that really the jurisdictions would find would have the best access to. So I wanted to ask, I'll ask just one question. Well, we're at time, but if you have any other questions, please go ahead and put them in the chat, and we'll try to follow up with you afterwards. Thanks so much, everyone.